Welcome to the deep dive. Today we're undertaking a really critical mission, synthesizing years of high-level research in applied physiology for acute and critical care.
hmm
We've taken a stack of sources, these key review articles from leading experts between 2002 and 2011, and we're pulling out the practical bedside knowledge that really defines modern practice.
And this deep dive, it's really meant as a shortcut for you. Whether you're a medical student just starting rotations or a seasoned pro who wants a refresher on first principles.
Yeah, that's a great way to put it.
Our source materials is just an incredible compendium, but reading through dense physiology can be, well, it's a lot.
Yep.
Our goal is to structure this, make it clear, and show you not just what to do, but why it actually works.
Okay, so let's jump right into the core of ICU management. And that really starts with the big question, right? Does this patient need fluid? For decades, the way we answered that was, well, it was guided by some pretty misleading metrics.
That's absolutely right. We have to start there by just acknowledging the huge limitations of the old static measures.
You mean CVP specifically, central venous pressure.
CVP, pulmonary artery pressure, or PP. The consensus now is it's unequivocal. These numbers are notoriously poor predictors of preload responsiveness.
They tell you the pressure, but not the function.
Exactly. They might tell you how much volume is in the tank, but not if adding more will actually make the engine run better. So that's where the shift to dynamic assessment came from.
Which is really all about heart-lung interaction. Explain the genius behind that.
It's just this beautiful example of interconnected physiology. So if you have a patient who is deeply sedated, completely controlled on a mechanical ventilator.
Right, totally passive.
Exactly. The cyclical inflation of the lungs creates these predictable mechanical effects. When the ventilator pushes air in, it increases the pressure in the chest.
And that squeezes the vena cava.
It momentarily reduces blood flow back to the heart. And if that patient is on the steep, volume-dependent part of the Frank-Starling curve,
Meaning they're fluid responsive.
precisely, then that little pressure change will cause a big measurable drop in their stroke volume and pulse pressure. But if they're already overloaded, they're on the flat part of the curve, and you won't see much of a change at all.
So the ventilator becomes this natural built-in stress test for the heart. What are the key parameters we're looking at?
The gold standards are the respiratory variation in pulse pressure. We call it delta PP, and stroke volume variation, or SVV. These are incredibly predictive.
And the data on this is pretty stark, isn't it?
It really is. When you look at the ability to predict fluid responsiveness, the area under the curve, or AUC, for SVV was about 0.82. For systolic pressure variation, SBV, it was 0.81.
And just to clarify for everyone, an AUC of 1.0 is a perfect test. 0.5 is a coin flip. So 0.82 is a strong predictor.
It's very strong. Now, compare that to the old standard atrial pressure, or RAP, which is basically CVP. It has an AUC of 2.45.
Wow. So it's literally worse than a coin flip.
It is. That single finding fundamentally changed how we practice medicine.
But of course, not every patient is that perfect passive candidate. What about arrhythmias, or if they're breathing on their own and triggering the vent? That messes up the whole rhythm.
And that's a key limitation. This is where we turn to the passive leg raising test, or PLR. It's an elegant, fast, and completely reversible self-volume challenge.
A self-volume challenge. I like that.
You smoothly raise the patient's legs, and you mobilize about 300 milliliters of venous blood right back to the chest.
So it's a transient internal fluid bolus. You don't even have to open an IV line?
Precisely. And the critical part is the changes you see are not affected by arrhythmias or breathing efforts. If you see a response, say a greater than 10% jump in aortic blood flow, that patient is very, very likely to be fluid responsive. It keeps its predictive power when the other indices fail.
And we can do this non-invasively too, right? With ultrasound.
Yes, ultrasound is critical here. You can look at the great veins, the SVC and the IVC. If the inferior vena cava collapses significantly when the patient inhales on the vent, it's a strong sign of low volume. It's an amazing tool for septic ventilated patients right at the bedside.
Okay, let's pivot from the macro plumbing of the system down to the micro level, where the real failure happens in shock. I'm talking about the microcirculation and the endothelium, especially in sepsis.
You've hit on the absolute core of the problem. The endothelium, that single layer of cells lining our blood vessels, is so much more than a passive barrier.
Right, it's an active organ.
It is. Normally, it's anticoagulant, anti-adhesive. It regulates vascular tone. But during severe sepsis, it undergoes this catastrophic transformation.
It essentially switches sides.
That's a great way to put it. It goes from anticoagulant to procoagulant, from anti-adhesive to intensely proadhesive. You get this dramatic upregulation of adhesion molecules like ICAM1 and E-selectin.
Like microscopic Velcro grabbing onto white blood cells.
Exactly. And that recruits them to the area, causing more damage, plugging up the capillaries. And on top of that physical obstruction, you get this thing called vascular hyporesponsiveness.
That's the central deadly feature of septic shock.
It is. It's caused by a massive overproduction of nitric oxide, NO, from an enzyme called inducible NO synthase, or INUS.
And the inducible part is key here, isn't it? The normal kind of NOSI is fine, but this one just goes into overdrive.
Precisely. This unregulated burst of NO causes profound vasoplegia. The vessels just get floppy, dilated, and they stop responding to vasoconstrictors. That's why managing septic shock is so hard. You can pour in pressors, but if the vessels won't squeeze back, the pressure stays dangerously low.
So if blood pressure isn't the whole story, how do we monitor for this hidden failure at the tissue level?
We have to look past the blood pressure cuff. I mean, simple things like skin temperature and capillary refill time, or CRT, are still incredibly valuable first-line checks.
Good old-fashioned clinical skills.
Never forget them. But for a deeper dive, we use techniques that measure tissue-level gas exchange.
Which brings us to sublingual capnometry.
Yes, brilliant concept. You measure the CO2 pressure right under the pung, the PSL-CO2. The important metric is the gap between that sublingual CO2 and the CO2 in the arterial blood.
And what does that gap tell us?
If the microcirculation is working, CO2 gets cleared out efficiently and the gap is small. If it's failing, CO2 builds up in the tissue and the gap widens. A difference of more than 25 millimole Hg is a sign of severe tissue hypoperfusion and a very poor prognosis. The waste gas just can't get out.
That is a powerful metric. And for the ultimate view, you mentioned actually visualizing the capillaries.
We can do that now. Using handheld video microscopes with technologies like orthogonal polarization, spectral imaging, OPS, or side-stream dark field, SDF, we can look directly at the sublingual mucosa and see the functional capillary density, or FCD.
Functional capillary density. So how many capillaries are actually open and flowing with blood right now?
Exactly that. It's the number of capillaries actively moving blood, and the studies are definitive. This FCD is much lower in non-survivors. It confirms the blood just isn't getting to the cells, even if the MAP looks okay.
Let's shift gears to respiratory management. It's easy to just focus on oxygen and CO2, but mechanical ventilation itself has these profound systemic consequences. Let's talk about ventilator-induced lung injury, or VILI.
VILI is so important. It's the recognition that mechanical strain on the lung, even a healthy lung, is not benign. The stretching and the shear forces release a flood of inflammatory cytokines, TNF-alpha, IL-6, into the bloodstream.
So it's not just a lung problem. It causes systemic inflammation that contributes to multi-organ failure.
Directly. And we have concrete evidence of how fast this happens. It's shocking. One study showed that switching patients from a protective strategy to a high tidal volume strategy, 12 milliliter per kilo, caused a significant spike in their plasma cytokines in just 1 hour.
1 hour, so the damage is almost immediate.
The systemic immune reaction is almost immediate.
And this need to protect the lungs is what leads us to the idea of permissive hypercapnia, or HCA, the trade-off we make when we use low tidal volumes.
HCA, right, the elevated CO2 and the resulting acidosis. It used to be seen as just a necessary evil, but now we have evidence that moderate HCA might actually be protective.
Wait, protective? So the high CO2 might actually be helping fight the inflammation. How?
The mechanism is complex, but it seems to involve inhibiting a key transcription factor called NF-kappa B.
Which is like the master switch for inflammation.
It is. It controls the transcription of most of the major inflammatory genes. So by partially suppressing that switch, HCA might actually dampen the whole systemic inflammatory response.
That's fascinating. A side effect that turns into a potential therapy. But there has to be a limit.
Oh, absolutely. This is not a free pass.
Yo.
While moderate hypercapnia can be helpful, severe hypercapnia, like what you'd get with 15% inspired CO2, has been shown to worsen neurologic injury. It is a very fine line.
Okay, let's shift the mechanical focus from the lungs to the heart, specifically the right ventricle. The RV is so vulnerable in ARDS. Why is it so sensitive?
Well, the RV is a volume pump, not a pressure pump. It's thin-walled, and it's highly sensitive to changes in afterload. And in ARDS, it's facing a perfect storm. The lung injury itself increases pulmonary vascular resistance, or PVR, from clots and capillary destruction.
And then the positive pressure from the ventilator is physically crushing those capillaries, making it even worse.
Exactly. It's fighting against this massive resistance, which quickly leads to what we call the vicious cycle of autoaggravation.
And that's unique to RV failure.
It is. The RV struggles and dilates. That dilation pushes the septum over into the left ventricle, which reduces the LV's preload. Less preload out of the LV means less cardiac output, lower systemic blood pressure.
And if the systemic pressure drops, the RV can't get enough blood flow through its own coronary arteries.
Precisely. The RV's perfusion drops, its function gets worse, the actual load increases even more, and the cycle just spirals toward end-stage failure. The clinical takeaway for you at the bedside is profound. You have to protect that RV by strictly controlling the plateau pressure. Keep it low.
For our final section, let's touch on some complex systemic issues, starting with a really dramatic one, the fallout from a subarachnoid hemorrhage, or SAH.
SAH is a classic case of a local brain injury causing a catastrophic systemic cascade. The event triggers this massive acute adrenergic surge, a flood of catecholamines. Epinephrine levels can hit 1,200 times the normal limit.
1,200 times normal. That is just an unbelievable stress state.
It is. And this storm causes specific reversible heart muscle lesions, mimicking a heart attack. At the same time, you get this huge pressure surge that injures the lung capillaries, leading to neurogenic pulmonary edema. It's a direct line from the brain to heart and lung failure.
Wow, that really underscores the interconnectedness of it all. Let's look at the blood itself. We talked about microcirculation failure, but what about the red blood cells in these low-flow states?
This is a key point. In sepsis or shock, when blood flow is slow, the RBCs themselves change. They lose their flexibility, their ability to deform and squeeze through tiny capillaries. They also start to aggregate, sticking together in these stacks called rouleau formation.
So instead of smooth, flexible discs, you get these rigid stacks of cells clogging things up.
That's the perfect analogy. And this dramatically increases blood viscosity, turning it almost into sludge, making microcirculatory flow even worse. The blood itself becomes part of the problem.
This all leads to our final and maybe most important management caution, the danger of trying to normalize everything.
This is paramount. Never blindly attempt to normalize all the numbers. History is filled with examples of this causing harm.
Right. We learned the hard way.
We did. Rapidly correcting sodium can cause central pontine myelonolysis. Using high tidal volumes to normalize the PASA2 and ARDS, as we said, was shown to increase mortality. The goal isn't a perfect set of numbers.
The goal is supportive care. Stabilize perfusion and oxygenation while the body heals the underlying problem.
Exactly. We provide physiological support using dynamic indices, protective ventilation, protecting the RV, while the definitive management, draining the abscess or stopping the hemorrhage, takes place. We have to treat the patient, not the number.
This has been an incredible deep dive, from the predictive power of hemodynamics down to the molecular failure of the endothelium and the systemic consequences of everything we do.
And that synthesis is the key. You have to integrate the macro, the micro, the respiratory, all of it to really understand what's happening to your patient and how to intervene. Critical thinking is everything.
So let's end with a final provocative thought for you to take back to your practice. A quick exercise based on what we just discussed.
Okay, here it is. Imagine your patient is on controlled mechanical ventilation, regular heart rhythm. Their monitor shows a stroke volume variation, or SVV, of 18%. Their mean arterial pressure, the MAP, is 58.
Okay, SVV of 18, MAP of 58.
What specific management step related to their volume status is strongly indicated by that SVV data, and why?
Remember our discussion. An SVV greater than 10 to 15% strongly suggests fluid responsiveness. Think about what that 18% is telling you about where they are in that Frank Starling curve and what action that information demands. We'll leave you with that, and we'll see you next time for another deep dive.